One very important decision when a patient is diagnosed with ovarian cancer we have to make is whether they are candidates for surgery or chemotherapy. So we're trying to figure out whether we do surgery first or we do chemotherapy first. In this video, I'll just share my thoughts as a physician, how I make this decision and what the data supports. So when a patient presents, there could be two different scenarios. If you watched the previous video about staging, I talked about this scenario number one, where the patient has metastatic disease. Now this often, if you remember from that video, patients are usually diagnosed with either stage 3 or 4 disease. And that's unfortunately an overwhelming majority of the patients with ovarian cancer. Now, one thing which just immediately puts us in a category of chemotherapy directly and not surgery is if they are stage 4. If the cancer is in the liver or in the chest cavity, there are some exceptions to this, but more often than not, if the disease has gone into the lymph nodes of the chest, most patients would end up getting chemotherapy first. If there's disease in the spleen, or in general, if we find that both for stage 3 and 4, if it is extensive disease. Now, having an extensive cancer with ovarian cancer is not just the criteria which will exclude you from getting surgery, but the criteria your surgeon or GYN oncologist is thinking is this one central question: am I able to remove all the cancer? This is a really, really important question because we know from lots and lots of years of research that patients who undergo surgery but we are not able to remove all their cancer and they have remaining cancer in the abdomen don't do as well in terms of their survival compared to the patients where we are able to remove every part of the visible cancer. Now, there's no way surgery can remove all microscopic floating cancer cells, but whatever the surgeon can see. So now immediately you can see like why patients with disease in the liver or the spleen or in the chest cavity are excluded. Now, there are exceptions to everything I'm saying here. There are times when the disease is in a very small portion of the liver, and if you're in a center where they are equipped to do so, a small portion of the liver can be surgically removed. But then the question is it possible in that particular area or institution where you're getting your surgery? Are they able to remove all the disease? But if your surgeon makes a determination and their answer is, nope, I cannot remove all the cancer, then immediately the next step is to start chemo. Now, there's a related issue to am I able to remove all the cancer is the second question we ask ourselves: is the patient able to tolerate the surgery? And the answer to this question depends on multiple different things. It could be that the surgery is too extensive. They are not in such a bad health, but the surgery is too extensive. It's going to require removal of portions of the bowel, like we talked about, maybe requires a portion of the liver to come out, gallbladder to come out, spleen to come out. And they're just older, and this surgery is going to be very difficult for them to recover from. So the answer, if the answer to this question is no, they are not able to tolerate, again, the next step is chemotherapy. There are other situations where the patient has really bad medical situations where they have maybe blood pressure or diabetes. Those are not well controlled. Again, they're not able to withstand a complicated surgery. They get chemo first. Now, if their medical health is in such a bad shape that they can't even undergo chemotherapy, we have a different problem. So that needs to be addressed, and conversation needs to happen with your physician to decide whether therapy is even warranted. Luckily, this is not a very common scenario. Oftentimes we see that when patients are really old and have multiple medical problems and they got diagnosed with ovarian cancer, that maybe we may be able to do some palliative chemotherapy, but this is not with the curative intent. So if the answer is yes to both of these questions, that the surgeon is able to remove all the cancer visible and the patient is able to withstand the surgery and tolerate it, then surgery makes the most sense in the beginning. Now, this question of surgery versus chemotherapy has been studied previously in multiple trials. The part of the problem with those trials, without going into too much details, is that some of these trials were done without much of a standardization. What I mean by that is the quality of the surgeons and the institutions was not standardized. But by and large, what those trials told us is both the strategy of starting chemo first, called neoadjuvant chemotherapy. So from here on, I'll refer it to as NACT. This followed by surgery when the cancer has shrunk, followed by more chemo after that, this approach is just as good as the approach of surgery first, followed by chemo. In the United States, over time, more and more patients are getting this approach compared to the surgery first approach. But I think this is a decision which needs to be made very carefully, because in some patients where the answer is yes and yes to both of these questions, they are able to tolerate the surgery and the surgeon thinks they are able to remove all of their cancer, followed by chemo. We have a ton of data from experienced institutions showing that the survival is best here. Now, there are some other factors which could be the reason the patient is undergoing chemo first rather than surgery. It might be that they're very symptomatic. They have a lot of fluid in the abdomen, and chemotherapy will give them the relief. But again, these are decisions which need to be made along with your surgeon, whether the surgery or chemo is the right answer. Now, when patients undergo neoadjuvant chemotherapy, typically the course of this path is that you end up getting 3 to 4 cycles, and that's the recommendation by the National Comprehensive Cancer Network guidelines. So I'll refer to these frequently in these videos. National Comprehensive Cancer Network guidelines are basically developed by a group of people from all the leading cancer institutions. This is a non-profit organization which gives the best, or the physicians and other providers who are a part of the NCCN, including some patients, they review all the data, and these guidelines are put out on the internet, and you can actually download them for free if you make an account at the NCCN website. In those guidelines, the team has reviewed all the best available literature that is available to us right now, and then the group has recommended that 3 to 4 cycles of chemotherapy followed by surgery and then followed by another round of 3 or 4 cycles is the best strategy. Now, typically what would happen in this scenario is that the patient will start the chemotherapy. So let's call it the cycle number 1, then they get cycle number 2, and then they get cycle number 3. In most cases, again, there are exceptions to this, but in most cases, the chemotherapy is typically given with 2 drugs called carboplatin and Taxol. And I'll talk more about the chemotherapy in a different video, but you're getting these every 3 weeks. So this is a 3-week interval, then another 3 weeks go by. So now 3 cycles have happened, and then typically there'll be another 2 to 3 weeks of delay to make chemo number 3, to give chemo number 3 some time to work, and then a repeat CAT scan is done here. Okay, so I'm going to make some more space here. So this repeat CAT scan is reviewed by the team, and then again the same 2 questions are asked by the team. Number 1 is the patient able to tolerate the surgery? So patient. And then the second one is the cancer responding to this chemotherapy, and has it responded enough that the surgeon is able to remove it all? In majority of the cases, we are able to take the patients for surgery over here. If the cancer is responding but not responding enough, and it needs some more time, then often in these cases more chemotherapy will be given, and then another CAT scan happens, typically 2 to 3 more cycles, repeat CAT scan, and again we ask ourselves the same questions. Is the patient able to tolerate the surgery, and is the surgeon able to remove all the cancer? So that's the usual decision making in neoadjuvant chemotherapy. On the flip side, if somebody was able to tolerate the surgery right up front, and their cancer is, the surgeon thinks that they're able to remove all the cancer, then we call it primary debulking surgery. And typically this is followed by 6 cycles of chemotherapy. But as you see that ultimately the patients are getting anywhere from 3 to 4 cycles before surgery, followed by 3 to 4 cycles after surgery. In this scenario, you're getting 6 and then sometimes 6 to 8 cycles depending on how the cancer is responding. There are several other things which happen during the chemotherapy, like monitoring of the CA120. If it is a marker for you, there are some questions. So let me just write it down here, CA125 question. Then there's a question about whether additional agents should be added to carboplatin and paclitaxel combination. And the one which gets added quite frequently is called bevacizumab, so I'll just write it as Bev, also known frequently as Avastin. And then there are some practical things when you're getting chemotherapy, whether you should be getting a port for chemotherapy, and some other related issues of chemotherapy. What can you eat, where you can go, and all these related chemo questions, and we'll address those in a different video. So I hope that this is helpful and gives you some idea of how the decision is made by your care team to decide between surgery and or neoadjuvant chemotherapy.